Hello, everyone. Good morning, good afternoon, or good evening, depends on your time zone. My name is Maha Aljuaid. I'm a part of Eastern Mediterranean Global Sepsis Alliance from Saudi Arabia. It's my pleasure to chair this session for day 2 from the 5th World Sepsis Congress. In this session, we'll talk about infection prevention in clinical settings and community settings. Thank you for our speaker, for our sponsors, as well as for our attendees. Please let me introduce our first speaker, Sir Jeremy Farrar. Professor Farrar, he is the chief scientist at WHO with great contributions to the medical literature. He is a clinical researcher in immunology, and also he is a chief scientist at Wellcome Trust. He is a known global leader in healthcare and was awarded several awards, including the 100 most influential healthcare leaders. It's my pleasure to introduce Prof. Farrar to talk about the sepsis challenges, Vis-A-Vis global health agenda. The floor is yours.
That's great. Thanks very much indeed for the very kind introduction, and it's a great pleasure to join the 5th World Sepsis Congress. And I'm really delighted because I'm also joined by Dr. Benedetta here, who is also a colleague from WHO, a wonderful colleague from WHO, who sadly has left Geneva now and is based in the WHO EMRO office. And Benedetta, we miss you very much, and good luck with the new work. So where to start? Firstly, the world looks incredibly discombobulated at the moment. We are going through a period of really, I think, profound disruption, challenging many of our assumptions about many different aspects across the whole of society. But of course, health, both national, regional, and global health, is caught up in that period of disruption. And I think we need to just at some point pause as clinicians, as scientists, as international agencies such as WHO, and just pause and reflect, what does this period mean for us, whatever our field of endeavor, here sepsis, infection control, but across the whole range of work from pandemics to non-communicable diseases, to the very foundation of science in health. And I think it's very important for all of us, whatever role we play, to accept that we're in that period of disruption, but then also try and find time to think how we can help navigate our organizations, our patients, our communities through this, because it's challenging all of us in different ways. And it's in challenging times that leadership really matters. And all of us on this call, in the World Sepsis Congress community, all of us have some degree of authority, of power, of agency, speaking for our community, speaking for our patients, speaking for our countries and agencies. And it's very important we use those voices at the moment to try and think through the period of disruption to something that's a better world at the end of it. At the same time as all of those challenges, of course, we also face huge global challenges, whether antimicrobial resistance, increasing nationalism, and a retreat from a sense that we're all in this together, whether it's in climate or antimicrobial resistance or pandemics. But equally, and I refuse to be pessimistic, we are also in a golden age of science. We really are in a golden age of science as a result of many countries around the world investing in discovery and basic science over 10, 20, 30 years. And the fruits of that are now coming into clinical and public health practice in ways that at the start of my career would be unimaginable. And of course, people often go back to COVID and talk about how we developed mRNA vaccines in a year during 2020 for COVID. We should just remind ourselves that the work that on the mRNA started 20, 30, 40 years ago, and the Nobel Prize was indeed awarded for work in the 1980s. It just shows that whether you're in public health, you're in critical care units, you're in community, general practice, whatever area of medicine you're in, discoveries are going to happen, and they're going to happen faster. And one of, I think, our challenges over the next 10 or 20 years is to ensure that the scientific golden age actually delivers in an equitable way for everybody in the world. And there is a danger at the moment, I believe, that unfortunately, none of us would want this. But if we are not careful and we're passive, my worry is that science will actually lead to greater inequality. the fruits of science will be available to a smaller number of people in a smaller number of countries. And what we must do, I believe, as a community, and particularly for WHO, is to argue that science works for everybody, and it must work for everybody. And a more inequitable world is a more dangerous world. And so through the current disruption, as you pick up newspapers or watch the internet or TV on a daily basis, let's just make sure that we keep a degree of optimism and hope that actually through this period of disruption, science and evidence can inform policy, it can make health better for all, and that we can ensure that science works for everybody. And including in those disruption, there is, of course, also questions of the fundamental value of science and the fundamental value of evidence. And again, we cannot be passive in this. I believe everybody on this call will actually believe that science works through challenge, it works through evidence, and it works through communicating that evidence to the broadest possible community, and that we base our policies and our clinical practice and public health practice on the best possible evidence. We must keep to that. We must rise to the challenge of the questioning of science and evidence, but we must do so in a dispassionate way that accepts the challenge but doesn't get intimidated by it or fall away from it. So what does all that mean for the community of the Global Sepsis Congress? Well, for me, in many ways, sepsis and not in the introduction, but having spent 18 years or so working in critical care in Vietnam, looking after a range of different patients with very variable conditions. Sepsis for me almost defines in many ways, a little bit like immunizations does and maternal and child health, it actually defines how well a health system is working. Because if you're going to address sepsis, you need to work at all levels of a health system. You need to work in the community to make sure that patients who are going to develop sepsis or have sepsis are identified. That means having good diagnostics. It means having a good system whereby the primary care system and your hospital system is well interlinked so that there is not a delay in patient care, and that people within communities appreciate the signs and symptoms of sepsis so that they can themselves act early, and our primary care nurses and physicians are aware of that condition so that they can be triaged quickly. Then when you get into the hospital setting, for me, sepsis is also an indicator of how well a hospital is actually working, because it means bringing together different diverse disciplines to address a common problem. It means making sure that microbiology and microbiology laboratories are functioning and communicating well to physicians, surgeons, and critical care physicians. It means ensuring that infection control and prevention of infection is absolutely the top of every hospital agenda, and that's why I'm so delighted to be on this call with Benedetta. And it means that in your care of patients, your use of antibiotics, your use of combinations, but also in the post-recovery phase, there is both physical and mental support for people recovering from sepsis. So for me, in a way, sepsis is a microcosm of how well a health system is working in an integrated way that brings together those diverse functions and doesn't allow things to drop between disciplines. It's when things drop between groups of teams not used to working together that things fall between, and then patients suffer. And for me, sepsis is all about the bringing together a team. The last point I'd like to make is about science and research and evidence. And I think the sepsis and critical care community have been extraordinary in bringing together networks of groups. I know the ones in EMRO region, I know the ones in the European region, Southeast Asia, Australian network I've got huge respect for, Canada, United States, Brazil, Central and South America, and increasingly South Africa, Nigeria, Kenya. These are absolutely critical. And they're not just critical when a pandemic strikes. One of the key lessons we all learned through every epidemic over the last 25 years is it is what structures, friendships, professional allegiances do you have before a pandemic hits that allows you to function? And those must be functioning all the time. As I say, bringing together all of the aspects that you require in order to deal with the critically ill patient. And therefore, the research and evidence needs to be built into that diverse team, and it needs to be functioning all of the time. So what I would implore is that the superb, outstanding critical care and sepsis networks are supported all of the time, are functioning all of the time, and are conducting the critical research that are answering questions that are raised every Monday, every Tuesday, and are also then able to pivot when a pandemic or an epidemic happens. And by doing that, and by sharing the information on infection control, on management of sepsis, that can then be shared at a global level, so that whether you're dealing with sepsis, let's say in Europe, which may be caused by a certain number of pathogens or conditions, there are lessons to be learned there in Southeast Asia and vice versa. And by building that network through the World Sepsis Congress, I think is our best ability to ensure that science works for everybody, that clinical science is shared around the world, and the diverse teams that are critical to addressing issues such as sepsis are in place all the time and functional. And where I would push the community, and this is now from a little bit outside the community now, is to embrace that opportunity, persuade the funders of the critical importance of this, and then remain open-minded about what are the best prevention and treatment options for how infection control happens, how you manage the hemodynamic instability, how you manage the pathogens that cause sepsis, but also critically, again, as we saw during COVID, what is the role of the non-pathogen management in terms of immune cascades and others. And I still think in the sepsis community, there is further work to be done on exploring how treatment can best work across those modalities of hemodynamic instability, endothelial dysfunction, pathogen-specific and immune modulatory. And bringing those together in regions and then globally, I think would push forward the whole evidence base on which we base our sepsis prevention, our infection control measures, and our management of patients, including the post-recovery period. So I'll stop
Excellent.
there and open it for any questions or comments.
Okay, thank you so much. I have actually, I need your comment and probably an answer of my questions. So what would be your recommendation for policymaker, probably countries like Vietnam and countries with low middle income to focus on sepsis prevention, because it's all into basic, I think, more than into advanced critical care to prevent sepsis before the patient reaches to ICU. And then my second questions, you've mentioned about different pathogens in different parts of the globe. So what do you think is the role of precision medicine in sepsis care?
Okay, so on the first one, I think for me, and I think this is the direction of travel that health systems globally are moving in the direction of, and that is integration. I think when things are fragmented, things get left out. If you have a primary health and community-based health system that is divorced from and separate to your clinical and hospital-based systems, then unfortunately patients will fall between the cracks. Anything that can be done at a policy level that gives patients a seamless process through which means community and primary care physicians and nurses are aware of the signs and symptoms of sepsis, the patient community and the communities themselves are aware of it, and then there is a seamless triage system that takes you at the speed that is demanded into the hospital system, and then the hospital system is established to deal with the diverse skills that you need of all the things I've mentioned. And that would be the integration, I think, is the key. I think things fall apart when there's fragmentation. The second one is precision. So precision medicine and whether led by genomics of the pathogen or the individual, I think are increasingly important. But I still remain of the view that there are areas across the sepsis world, different pathogens where there are common pathways, and we need to explore there so that bacterial sepsis can learn from non-bacterial sepsis. We can learn more about the endothelial dysfunction. We can learn from dengue shock syndrome across to other causes of pathogenesis. And I believe there will be immune modulators that can be used and tested at scale, which will be beyond precision medicine and may be of benefit to multiple sepsis syndromes. How we've identified those across the complexity of the sepsis community, patient-wise, I think is our challenge.
Excellent. Thank you so much. Well said. I would like to introduce our next speaker. And thank you so much, Prof. Jerome. So our next speaker is Professor Benedetta Allegranzi. Dr. Allegranzi is a well-known WHO staff. She is a global leader and she leads the infection prevention, control and integrated health service at WHO. She had multiple publications within WHO and other scientific journals platforms. She will talk about the global action plan and monitoring framework to prevent sepsis acquired in healthcare setting. The floor is yours, Dr. Benedetta.
Good morning, everyone. Thank you very much for your introduction, Chair, and thanks a lot to the Global Sepsis Alliance for organizing this very important Congress every year. So I'm also particularly honored to follow the speech of Professor Farrar, because there are so many things that he said I totally agree on, and also I wanted to convey through my presentation. My presentation, as you know, is specifically focused on healthcare-associated sepsis and infections. Other colleagues will also talk about the community setting and how to prevent sepsis in those settings. So as you may remember, WHO issued a global report on the epidemiology and burden of sepsis and in 2020. And we also conducted several studies to support the evidence included in this report. And one of the studies we conducted with Charité, Berlin, Germany, was a review to estimate the proportion of sepsis cases that are healthcare associated. And indeed, 1 in 4 cases are acquired in the hospital, so about 25–30%, some other studies say are acquired in healthcare settings. The mortality and consequences of these particularly severe cases of sepsis is overall about 24%, but it increases to more than 50% of cases in ICU-treated patients. It also has consequences on the length of stay by increasing it by 2 to 3 times compared to community-acquired sepsis. And a big issue of healthcare-associated sepsis is its association with drug-resistant bacteria, which actually make very difficult treating these cases, in some cases impossible to do so. So this is why I would like to talk about the fact that there are really very close interconnections between healthcare-associated infections and AMR and the consequences that these lead for patients. And indeed, worldwide, we know from recent estimates, there are 136 million hospital-associated antibiotic-resistant infections per year. And we also know, for example, in Europe, that healthcare-associated infections account for twice the burden in terms of premature mortality and disability, twice the burden of the other 32 infectious diseases monitored by ECDC in Europe. So this means, as you can understand, that indeed, healthcare-associated sepsis might be a lower proportion compared to community-acquired sepsis, but the consequences, also based on data, are quite higher than community-acquired infections, which are accounted among those 32 infectious diseases monitored by ECDC, for example. Another piece of data which is really important, again, to connect the dots, is that a few studies highlighted that 70% of the burden associated with antimicrobial resistance is due to healthcare-associated infections. So again, all these things fall together in a very nice way according to the evidence, showing consistency and showing that the AMR problem is underpinned by acquisition of this type of infections in healthcare, and this can then evolve to sepsis and therefore be untreatable, not treatable because of AMR. And indeed, this is also something that can be seen while looking at for example, the deaths associated with antimicrobial resistance, which were recently estimated to be around 5 million overall. And then in a very recent study conducted by WHO and OECD, we could assess that 3.5 million deaths occur every year up to 2050 due to healthcare-associated infections. So once again, there's a big toll on deaths by both HAIs and AMR, and this translates often in the evolution to sepsis and mortality attributable to healthcare-associated sepsis. And this, in terms of the mortality rates attributable to HAIs, according to our study, varies according to regions and especially to income level, with low middle income and low income countries most affected by these annual mortality rates. So what is the solution? The solution is to strengthen infection prevention and control programs, among other interventions, of course, and my colleagues will talk about other interventions as well, to prevent healthcare and community-acquired sepsis. But the focus of my presentation is to make you aware that over the last couple of years, and building upon the lessons learned from the COVID-19 pandemic, all member states recognized the importance of strengthening efforts on infection prevention and control, and developed and approved a global strategy and action plan on this area of work, so that IPC is embedded across the entire continuum of the health system in each setting where care is delivered, with the main vision to achieve by 2030 that everyone accessing or providing healthcare is safe from associated infections. This global action plan and strategy have 8 strategic directions, which are key, and I encourage you to look at this into the details. But within the global action plan, basically, according to each strategic direction, we indicate to countries and also to healthcare facilities actions that can be made to achieve those strategic directions, and also specific targets that the World Health Assembly has adopted by 2030 related to infection prevention and control. But now, how to motivate people to uptake this global action plan and translate it in national action plans and integrate it with other efforts? Data to motivate people are included in 2 recent WHO publications, a global report and the case for investment in infection prevention and control. The global report highlights that the global situation with regards to actual implementation of IPC programs at the national level still has a lot of gaps, with, for example, only 44% of countries having dedicated budget for IPC, and only 38% of countries implementing IPC programs nationwide, despite of the fact that 93% of countries report to have a national program or plan, but this means that it's not well implemented. Also, there are gaps in water, in WASH, that will be highlighted by my colleague from UNICEF later. But sadly, we also detected that only 6% of countries meet all the minimum requirements that WHO set for IPC at the national level. And at the facility level, we detected that only about 16% of a sample of facilities meet all these minimum requirements. A bit higher percentages meet at least 90% of these minimum requirements. There are many gaps in terms of budget allocation, but also training and education, HAI surveillance and monitoring and evaluation of IPC programs at the national level. And at the facility level, again, we can see remarkable differences in facilities depending on the level of income of the country where they are, with much lower implementation of the minimum requirements in low-income countries and lower middle-income countries. With, again, big gaps at all levels, especially in low-income countries, including the lack of routine microbiological laboratory support, which is a clear element that then drives lack of diagnosis of the cause of sepsis, and therefore the impossibility to target the treatment, the antimicrobial treatment. There is a lot of evidence about effectiveness of prevention interventions, and this is the Lancet series published last year, which show that simply implementing IPC and WASH standards, we could prevent up to 600,000 deaths in low-middle-income countries and already achieve the target that we have worldwide to reduce by 10% the proportion of deaths due to antimicrobial resistance. WHO and OECD also demonstrated similar effectiveness, in particular talking about multimodal IPC interventions at the point of care, where we demonstrated that worldwide more than 800,000 deaths could be prevented by these interventions due to healthcare-associated infections. And we also demonstrated, and in particular OECD demonstrated, that the economic return in IPC investment could be very high, showing that WASH, hand hygiene, and environmental hygiene in healthcare facilities are the most effective interventions to reduce AMR over all interventions. And in this recent study we undertook with OECD, we demonstrated that IPC interventions at the point of care could be leading to savings in healthcare expenditures as high as $112 billion up to 2030 every year, and also economic gains of 124 billion. So big, huge return on investment from the economic and also the health point of view. We have targets to achieve improvements of a number of indicators pertaining to IPC action at the national and facility level, which are included in the Global Action Plan and Monitoring Framework for IPC. And as I demonstrated, and we know, we have clear guidance now, Global Action Plan and Monitoring Framework for IPC, but also we have the Global Agenda for Sepsis, which mentioned the importance of preventing sepsis in healthcare. So we have all the bases, technical, but also strategic. And what we need on the way forward is integration of strategies and actions, as Jeremy very well highlighted before. We need more global, but especially local leadership and advocacy to take up these strategic documents and translate them into implementation at the point of care and in health systems in their countries. For doing this, investment case, information and data related to the local reality would be very useful to motivate why to invest and why to finance. In particular, in this case, IPC programs at the national and facility level, but also why to invest in WASH, in vaccines for prevention. And we need to be accountable in tracking progress, but also remaining gaps at the global and local level.
Thank you so much, Dr. Benedetta. So there is a comment from the audience that the audience, I believe, from South Africa, and in her comment, she put that our facility used a wrong tissue paper dispenser, and that discourages staff from appropriately performing hand hygiene. I think basic things like using wrong products is another discourage factors for basic infection prevention practice like hand hygiene, which is very important. I appreciate the statistic you shared with us, a very informative presentations. If you would like to comment on the feedback that from the participant, and then I have a question to you.
Yeah, so the participant highlighted that often the necessary supplies for example, for key interventions such as hand hygiene, are lacking at the point of care. And so using the approach I explained in my presentation, there is need for IPC professionals at the facility level to advocate with their managers about the return on investment in investing in hand hygiene. Hand hygiene is the most cost-effective intervention among all, demonstrated by evidence. And therefore, please, I would like to encourage this colleague to look at this investment case document, which includes data about the return on investment in hand hygiene, to convince managers at the facility level why to invest in hand hygiene and purchase and procure and position at the right place hand hygiene supplies.
Thank you. So if in 15 seconds, could you give us what would be your motivation to global movement toward prevention of hospital-acquired infection?
The motivation was given in my presentation, which is that one, healthcare-associated infections are the predominant contributor to AMR. AMR makes sepsis cases very difficult to treat and is one of the main reasons for mortality due to sepsis in healthcare and also in the community setting. And therefore, these are the key aspects to be tackled. And this is why I think that establishing and implementing IPC programs at the national and facility levels is paramount for the resolution of the problem of sepsis.
Thank you so much, Dr. Benedetta. Very informative session. Our next session will be a recorded session. It is from Professor Claudia Spies. Dr. Claudia, she's a professor of anesthesia and intensive care medicine at Charité University and Medical Center in Berlin. Her focus of research is in post-intensive care syndrome and how to reduce anesthetic agent in the ICU to reduce delirium and cognitive deficit after ICU discharge. She will talk about the rapid diagnostic and diagnostic stewardship for preventing of infection, evolution to sepsis. So our colleague from NC3 will share with us Dr. Claudia records.
Hello, everybody. Sepsis is a very common disease. 50 million people are diseased every year and 11 million die from sepsis, 3 million children. And 20% of all global deaths are related to sepsis. The underlying causes are usually infections. And I would like to talk a little bit about diagnostic stewardship. And diagnostic stewardship focuses mainly on testing, and it's defined as having the right test for the right patient at the right time to improve the entire diagnostic process. And that means from starting the probes, the samples, to get the tests reported. And from that, the right test, what is the key question? Is the test appropriate for the clinical setting? And for that, sensitivity and specificity is relevant, predictive values, testing volumes. Do you have a diagnostic yield, a lab feasibility? This is very important because many of these centers do not have the lab feasibilities, costs, and clinical impact. And the right patient, so will the clinical care of the patient be affected by the test? So you need lab test utilizations, you need CPOE decision supports, and I think it's very important that you integrate that in a standard of operating procedures in your department. And the other thing is, will the results be available in time? So time to specimen receipt and centralized versus point of care testing is important, as well as the runtime. So usually what's the current clinical workflow for the management of sepsis today? So still blood cultures are the cornerstone for microbiological disease. And as you can see here, from the time when the patient gets sick to the point when the patient gets the right antibiotics, it takes a long time, usually at least 5 to 7 days. And the turnaround time of microbiologically positive blood cultures with antimicrobial susceptibility testing is around 48 to 72 hours, even with automated systems. And this is important that you don't get the results of the AST earlier. And other biomarkers count lack of specificity in these patients. So we started a long time ago in our department with RT-PCR methods to get the results for pathogen identification and therapy adaptation. And as you can see here on the right side, this is the panel of the SeptiFast, and it had 25 species to be determined within 24 hours. And as you can see here, the time to pathogen detection in the blood culture was approximately 1.5 days. And here, for the first time, you got some of the results, and to SeptiFast, it was quite shorter. And this also meant in neutropenic patients that you have a change to the targeted antimicrobial therapy at least 1 day earlier. And this means that you can change according to these earlier for the right treatment in both of these studies. But it's still not that easy because these rapid diagnostic methods are still lab associated. So compared to conventional methods and modern methods, advanced methods might be in the future that they don't need these direct support by high specialized lab facilities. We are on a good track from conventional methods with blood culture, CT, to modern methods. So you can see here PCR or RT-PCR, as I already told you, but also multi-TUF options are available here. And next generation sequencing is also relevant within these lab facilities. And this gives you rapid identification methods. I think it's very important that they reduce mortality, morbidity, hospital length of stay, antibiotic use, or healthcare expenses. That needs to be shown for the clinical part, so the patient-centered outcomes are very relevant in these settings. So usually there are a lot of commercially available approved diagnostic molecular technologies, and many of them, as you can see here, require still a blood culture and a gram stain, and they are related like multi-TUF, etc. Here, as you can see here, if you have that result within the first 8 hours, then it's quite fast to get the further results by specialized methods. But if you want to have it shorter, it's very expensive still, like here with the septicide, and it's really related to a good lab facility. So we use, for example, also Discover methods for NGS, that's microbial cell-free DNA metagenomic sequencing, and this gives you some results within 24 to 36 hours, but still, is relevant with respect to some pathogens that are, have problematic identification in polymicrobial samples. And it's also related to the ability to identify only these online panel organisms. It still relies on gram staining and has poor identification performance for some species. And besides that, there's a rapid diagnostic methods. I think it's important to consider that and to work on that this needs to be improved. In addition to these pathogen-related diagnostic markers, you also have a lot of other biomarkers available. And as you can see here also, these markers are markers that should have a high sensitivity and specificity, provide a rapid and precise results, serve both as diagnostic and prognostic markers, and offer valuable prognostic information for the patient outcomes. This is important. So you can measure a lot, but I think that the most important thing is how prognostic is this information for the patient, ensure reliable performance across different populations and settings, and needs to be cost-effective and non-invasive. And all these markers can be easily integrated in MI learning algorithms and used, but they'll it's not available in every hospital and it's not available in every setting. And this makes it difficult at that point. I want to come to a very easy thing that can be done everywhere, even by not specialized healthcare workers. And then what you can see here, capillary lactate, can be also integrated in these algorithms. And I think it's important that this is seen in a monocentric study, for example, with 28 mortality with a lactate on admission, and this is related to ICU admission, vasopressor requirement, and mortality. But also lactate clearance 6 hours later gives you a good result in these settings. This needs to be integrated, however, in a structured clinical pathway where you can see if that works with your patient or if it doesn't. And it's important to integrate that and check for that. And in the future, maybe we will have non-invasive lactate monitoring by biosensors. You can see that in athletes. So for sports medicine, it's well often used. But still in critically ill patient, it requires some changes, either from the electrochemical sensors or from semiconductive sensors. And I think this is at least a way in the future to work on this and to have that available in every setting. And this makes it easier than to have it only in certain settings. In addition, we have a lot of electrochemical point-of-care devices for the diagnosis of sepsis. This requires a platform, and I think for that it's important that we profile the immune system, the host response, and the rapid detection of the pathogens. And this needs to be integrated. Electrochemical sensors show a lot of options in this setting. However, they have multiplex detection. The sensitive detection from the whole blood is not always possible. You have sometimes low bacteria concentrations, for example, in particular in children. This makes it difficult to achieve proper sensitive detection, and sometimes it requires large volume processing. This is also still a limit in these electrochemical point-of-care devices, but however, I think it's a way to go forward and to get that integrated. In addition, there is a strategy for development for point-of-care devices. One is that you use current assays, that you use the host response, as I told you. And in addition, you have hypothesis-driven device development and biomarker discovery that's increasing over the last years and will be integrated in AI models that can reduce the time from the patient feels normal, as I told you in the beginning, to the point that the patient have identified pathogens, and this can be reduced, to my impression, to 1, maximum 2 days, and this is quite faster than it's now, and this is probably then related to less multiple organ failure in these patients. So the point-of-care technologies for sepsis diagnosis and treatment that should provide the critical information regarding sepsis, including both pathogen-related and host response information on a lab-on-a-chip device that gives you MDR signals or hints to targeted antibiotic treatment. And it should provide molecular identification of the pathogen and the quantification of host response biomarkers. So coming up with a recent advancement, the FDA cleared the Triverity test that use host response mRNA amplification and ML classifiers. As I told you, an integrated approach was only in the emergency department so far. But as you can see here, bacterial infection, viral infection, and prognostic scores are very good integrated into the routine. And I think what's important is that even patients now scored on low risk for sepsis have a 50% multiple organ failure after 7 days. And high-risk patients have a higher risk to have that, but still also have resources allocated to them that they don't require. So I think on one hand, it's a better screening, the better resource they get, and to avoid resources that can be used at least for other patients. So I wanted to show you a new approach, and I think this is also very good from the host response. So usually a proteasome, and this is published in Nature, this January showed that you have a garbage that's detected and that's cleared by proteasomes. But proteasomes have an additional function. They constitutively generate antimicrobial proteasome-derived defense peptides. And these cationic peptides disrupt bacterial membranes and function independently of these immune cells. And you can get hundreds of thousands of potential PDDPs in the human proteome, and they inhibit Salmonella, E. coli, and Pseudomonas aeruginosa, and this is comparable to the effect of antibiotics in mouse pneumonia and sepsis models. And I think that can be a novel cell autonomous defense mechanisms that can be a source of natural antibiotics for resistant infections. And this is in particular in some cases where you have the resistant strain relevant. For example, if you do a surgery in a multi-resistant situation, for example, in patients having no infection, but having colonization, and you require, for example, a treatment for transplantation, for example, and then you might have the potential source of these BDDPs, for example, in a stem cell approach that gives you an option to treat these patients. So I want to summarize. I think there's a good outlook where we are going. There's an individualized medicine approach combining targeted diagnostics tests together with therapeutics. And this is something that a colleague from mine generated from ChatGPT. And what you can see here, the rapid tests for sepsis. So you get information in an integrated model where you have multi-marker approaches of the host and the pathogen to get a personalized antibiotic treatment. It should be affordable and a rapid point of care system. Host response gene transcripts should be identified before clinical deterioration. AI and automation is important, so you need structured, annotated data with a terminology that makes sepsis predictive and intervenable. And the integration in the routine clinical workflows is mandatory. So thank you very much for your attention. Very interesting meeting, and I hope I get your questions and can answer them. Thank you very much.
Thank you so much to Dr. Claudia. It was a very informative session. For the sake of time, we will move to our next speaker, Dr. Mateusz Hasso. Dr. Hasso, he is a technical officer at WHO in the field of immunization and vaccine biology. He is a PhD holder in vaccine immunology from London School of University, and he will talk about the preventing of sepsis using vaccine that reduce antimicrobial resistance. Dr. Mateusz, the floor is yours.
Thank you so much, Maha, for this introduction, and thank you for the organizers to invite WHO to present on this important topic. I am Mateusz and I work in the WHO in the immunization department, and today I will talk to you about how we can prevent sepsis using vaccines, but also vaccines that particularly reduce antimicrobial resistance. And let me just start with this slide that summarizes the burden of antimicrobial resistance. This is data that is shown from the Global Burden of Disease study, which has estimated that in 2021, there were 4.7 million deaths associated with bacterial AMR globally. And that number is predicted only to rise over the next couple of years. There are a number of pathogens that are causing this high burden, but the three leading pathogens with the highest burden are Streptococcus pneumonia, Staphylococcus aureus, and E. coli. And these three pathogens collectively are responsible for around 2.3 million deaths associated with AMR in 2021. So how can vaccines reduce a proportion of this very high burden of antimicrobial resistance? Well, they prevent infections that are both caused by drug-susceptible and drug-resistant pathogens. They can also prevent you individually from getting sick with a drug-resistant pathogens, but also if a number of people in a community are vaccinated, they can protect these communities from getting sick through herd immunity. Because they reduce the number of infections and then they reduce you and communities from becoming sick, they also decrease the antibiotic use, that is, antibiotics that are often prescribed to treat these infections in the first place. And because all of these factors collectively, they also suppress the possibilities of evolution of resistance genes, and they decrease transmission of resistant pathogens in communities. In addition, we had looked at WHO as to what are the priority vaccines which we need to develop for endemic pathogens. And last year we had engaged with countries and with regions to hear their feedback as to what is important when it comes to priorities for vaccines R&D. And what we have found through this engagement is we had identified 17 priority endemic pathogens for vaccines research and development. You can see them on the right-hand side. But what I would like to point out here is there are a number of pathogens here that are the cause of sepsis: Staphylococcus aureus, Klebsiella pneumonia, E. coli, and these are priorities for vaccines R&D. And importantly, also these pathogens are highly resistant to existing treatments. What we had also done together with partners is we really wanted to understand if we have vaccines in place against these important AMR priority pathogens, what will be the value of these vaccines in reducing antimicrobial resistance? And we had conducted a number of analyses for 24 different pathogens and 44 different vaccines against these pathogens. And what we had found that if we were to collectively have vaccines against these 24 different pathogens, together, these vaccines could have very high impact. They could collectively avert up to 515,000 deaths, 28 million DALYs, around $30 billion in hospital costs, around $20 billion in productivity losses, all of these factors associated with AMR, and all of that is per annum, and around 2.5 billion antibiotic doses. And I'm not saying that we'll be developing these vaccines against all of these pathogens, but this is just to highlight that there is really huge untapped potential that vaccines could take us to if we were to be able to develop them and then use them effectively. So I'll just zoom in on some of the results that I have touched in on the previous slide. One of them is the criterion as to how vaccines can impact AMR-related health burden. I've mentioned that collectively, if we were to develop these vaccines, we could avert up to 515,000 deaths associated with AMR. Majority of that averted burden will be in the WHO African region, around 32% of these averted deaths. And if you look at the graph on the right-hand side that shows the impact of different vaccines, you can see that the second, third, and fourth vaccines against Klebsiella pneumonia, against XBEC, against Streptococcus pneumonia are caused by pathogens that are often causing sepsis, and very high numbers, almost over 60,000 deaths associated with AMR that could be averted by these vaccines. Then if we look at antibiotic use, what we had found that collectively these vaccines could avert up to 2.5 billion defined daily doses of antibiotics, which is around 22% of the total burden that we have evaluated, and a large proportion of that burden is in the Southeast Asia region of WHO. Around 40% of that burden is in that region. And if you look at the graph on the right-hand side, the second vaccine, which is the XBEC vaccine, and the third vaccine, which is the Staph aureus vaccine, they are vaccines that could have very large impact on averting a proportion of antibiotic use. And lastly, another way to look at these results is also to look at the potential of these vaccines on averting hospital costs that are associated with antimicrobial resistance. The total impact of these vaccines could be around $30 billion US dollars annually in hospital costs. And these are the hospital costs that are associated with treating drug-resistant infections, so the incremental cost of treating these resistant infections. And that could be the cost of treatment, that could be the additional length of stay. And what we had found is that majority of that cost, around 30% of that $30 billion annually, is in the American region, which is expected given that there are very high costs of treating patients, particularly in the United States. And if we see in the graph on the right-hand side, you can see that vaccines that would have the highest impact is Staph aureus vaccine, over $8 billion annually, XBEC vaccine, around $7 billion annually, and then Klebsiella pneumonia vaccine, just short of $2 billion annually. All of these pathogens that are often causes of sepsis. So this was a report that we had conducted, which looked at a number of different pathogens and applied a systematic similar methodology in order to be able to compare what is the impact of these vaccines. There are also additional studies that were evaluating what could be the impact of vaccines on particularly sepsis. And this one study, it estimated the impact of vaccines against Klebsiella pneumonia to reduce AMR, but also to reduce neonatal sepsis. There are around 1 million newborns who die every year with neonatal sepsis, and Klebsiella pneumonia is one of the leading causes of such infections. A large proportion of these infections, 50 to 80%, are resistant to standard treatments with ampicillin and gentamicin. And there is also really high resistance to second-line therapies, which make these infections particularly difficult to treat. So what colleagues at One Health Trust and Princeton University have done is that they had modeled what could be a potential impact if we have a vaccine that will be given to mothers who are pregnant. We immunize these mothers who are pregnant, and then when the child is born, they already have some antibodies that would protect them from neonatal sepsis. And such a vaccine would be around 70% efficacious, and the coverage of that vaccine will be comparable to what we currently have with the maternal tetanus vaccine. And they had estimated if these scenarios would come into effect, such vaccine against Klebsiella pneumonia would prevent around 400,000 cases of neonatal sepsis and around 80,000 neonatal deaths annually worldwide. And around 50 to 80% of these are associated with antimicrobial resistance. So really very, very high impact. And importantly, data that informed this modeling analysis came from countries where Klebsiella pneumonia is a major cause of neonatal sepsis. So from South Africa, from Rwanda, this is data that came from CHAMPS, Barnard's, and NEOP studies, which are studies that are looking at etiology of the reasons why children are dying and looking at particular pathogens that are causing these diseases. So really well-informed studies by local data to estimate impact of vaccines on neonatal sepsis and AMR. And then another study, these are analyses that were conducted by colleagues at the Gates Foundation, which is another maternal vaccine. This time, this is a GBS vaccine, group-based streptococcus. Around 22 million pregnant women are colonized with group-based streptococcus. And if we were to have a vaccine that would be given to a pregnant woman, such vaccine could induce antibodies which could be passed on to a child. And as a neonate, such child could have these antibodies to prevent them from having a GBS disease. And what they had found is that such a vaccine could prevent around 300,000 cases, around 90,000 infant deaths, mostly neonatal deaths, and around 57,000 stillbirths that are due to a GBS cause. So again, a very, very high impact of such a vaccine. So just to conclude, I think what I wanted to highlight is that vaccines are a very important tool of the overall AMR strategy. You know, as we heard from previous speakers, in addition to IPC measures, in addition to diagnostics, in order to tackle AMR in its totality, we must consider all the different interventions, and vaccines are definitely one of them. However, they continue to be under-recognized as appropriate tools to reduce AMR. And we believe that, you know, through the analysis that I have just shown you, to understand what is the potential of vaccines in reducing AMR, we can help to address that. And one of these analyses where we found that vaccines have this potential to annually avert up to 550,000 deaths, $30 billion in hospital costs associated with AMR, and around 2.5 billion antibiotic doses annually. And we have seen that within these numbers, there are some specific examples of pathogens that are causing sepsis, and these are priorities for WHO to develop vaccines against these pathogens, particularly for GBS and particularly for Klebsiella pneumonia. Thank you.
Thank you so much, Dr. Hasso, for your elegant presentation. I was actually amazed about the statistics you shared with us. And there is a comment from one of the attendees. I'm not sure if he or she, but is asking about if these data are recent data about the role of vaccine in AMR.
So the data that I have presented, this is a model data, and it's just been published last year in a WHO report. It is using data from the Global Burden of Disease study from 2019, but it is also using data from local studies like the NeoNAP studies or the CHAMP studies, etc. So it's really a mixture of different data that first fed into the Global Burden of Disease studies and then informed that modeling report that we had published last year.
Excellent. If you allow me, I have a question. How you think we can balance between motivating communities and society to vaccine their children and access actually to vaccine and stewardship programs in low-income settings?
I think that the challenge here is we need to ensure that we communicate very well with the caregivers and with the healthcare workers so that we explain the benefits of vaccination in simple terms. But also when we do that, we very much listen what the concerns are of the caregivers. What is it that you are not sure about a vaccine? What is it preventing you? Very often, it's not just the hesitancy that we assume, but it's often the inability to access the health center, challenges with finding the right time to go to the health center, or when you arrive at the health center, it might be a long waiting time that may prevent you to stay enough or in a long center to be able to get vaccinated. So I think it's the ability to listen and understand all these different challenges and then adjust and tailor your communication to be able to answer these challenges and really help the caregiver to find the right time and then to be able to vaccinate a child.
Okay, there is a final question from the attendees. Question related across reaction to the pregnant woman or to the mother for this vaccine. Is there any study that you are aware of across reaction to the women or to the pregnant mom?
So the vaccines that will be given to mothers, they will induce immunity in mothers, and then that immunity will also be shared with an infant. So theoretically, mothers should also be protected against some presentations of this disease, as well as the infants within the first few months of life, as long as they have the antibodies, which of course later decay. And then usually after 3 months or so, we would expect that that child would no longer be protected against that disease. However, at that time, the highest risk of neonatal sepsis is much lower, and therefore there are much higher chances of a child surviving.
Thank you so much, Dr. Mateusz, for a very informative presentation. I'll take the opportunity to introduce our next speaker, Dr. Lindsay Denny. She is the lead of the WASH initiative in UNICEF and other NGO organizations. She helped multiple countries in WASH health initiatives. She's a graduate from public health and from University of Boston, International Health and Infection of Non-Communicable Disease. She will talk about WASH as an infection prevention measures to prevent sepsis. Dr. Lindsay, the floor is yours.
Wonderful. Thank you. Good morning. Good afternoon. I'm Lindsay Denny Naughton, a WASH specialist at UNICEF headquarters, and I'll talk today about WASH as an IPC measure for sepsis prevention. So what is WASH? Why was I invited here following these esteemed colleagues? WASH is water, sanitation, and hygiene, and these are tools in our public health toolbox that can be used to prevent and control the spread of diseases, similar to vaccines, as we've just heard, as well as social distancing. And for those of you who are unfamiliar, I'm not sure we have many WASH expertise in this Congress today. When we talk about WASH, we're referring to water, which includes water access, distribution, storage, treatment, wastewater, and source protection, all with the goal of ensuring that you have access to safe water for drinking and consumption. Sanitation looks at toilets and latrines, as well as the aptly named fecal sludge management, which is exactly what it sounds like, the management of the fecal waste from toilets. And again, the purpose of this is to ensure that you don't come in contact with the fecal waste. And lastly, we have hygiene, which looks at hand hygiene, as well as personal hygiene and menstrual hygiene. And the WASH sector focuses on specific contexts. So we work in community settings where we ensure that there's access to WASH in households. We also work in schools and healthcare facilities. And I'll spend some of the time today talking a bit about that latter setting and the particular impact of ensuring we can prevent infections in healthcare facilities to stop the potential for sepsis. How do we know that WASH works? Well, for those of you who are familiar with Dr. John Snow and the Broad Street pump from the famous removal of the pump handle to stop the cholera outbreak in London in the 1850s, we have seen the impact of sanitation on public health. So much so that it's been hailed as one of the top public health achievements of the 20th century. And in the WASH sector, we talk about the F diagram. This is the fecal oral cycle, and it demonstrates how we can prevent the spread of feces through fingers, flies, fields, fluids, and food to a new host. And you can see that WASH is a key set of barriers to prevent this transmission. So a toilet barrier, for example, can prevent feces from coming into contamination with fluids or drinking water, which then would reach a new host. I think what's critical when we talk about the prevention of sepsis is if you think about feces and replace that with really any infectious pathogen, the role of WASH and in particular hygiene is to make sure that we're interrupting that transmission before it can become an infection. What I'm talking about is fairly basic, right? These are basic interventions, something that if you grow up in a high-income country, you would expect to have available. So where are we with the global status of WASH? In fact, billions of people have gained access to WASH services since 2000. We've made tremendous strides, in fact, cutting in half reduction of DALYs related to diarrheal disease. But WASH still has major concerns in particularly low and middle income countries. In 2022, globally, 25% of the world lacked access to safely managed water. That may not sound like much, but that's still 2 billion people. 43% of the world lacked access to safely managed sanitation. That's 3 billion. And 27% lacked access to basic hand hygiene or soap and water at home. That's 2 billion individuals. And still, 1,000 children under 5 die every day from infections caused by unsafe WASH services. I want to take a moment to talk about climate change, because climate change is absolutely impacting the access to WASH services. Whether it's too much water, not enough water, or too polluted water, it's predicted that 2/3 of the world's population will live in water stress conditions by this year. This can reverse or backslide the access I've just spoken about over the last 25 years on WASH. It's also going to increase the spread of infectious diseases by reducing the water quality, making it so that you cannot wash your hands or cannot manage sanitation. To take a specific focus on healthcare facilities, if you think about where we are most concerned about being able to control infections, and you think about the density of pathogens and vulnerable patients, healthcare facilities are the perfect storm. And so it's particularly concerning to see that 38% of healthcare facilities globally lack basic water services. 68% of healthcare facilities in the least developed countries lack basic hygiene services. 81% lack basic sanitation services, and 69% of healthcare facilities in the least developed countries lack basic medical waste management services. All of this means that billions of people in least developed countries are accessing a healthcare facility that is unsafe. We heard earlier from our esteemed colleague, Dr. Benedetta Allegranzi, who spoke about the IPC program at WHO. And I want to point to one of their fundamental documents about the minimum requirements for IPC. We see that the built environment is really foundational to ensuring that you can have an effective IPC program. And it notes that you need a clean and hygienic environment with WASH infrastructure and services, as well as appropriate IPC materials and equipment. And the interrelationship here is sort of like a Venn diagram. And I use this diagram to demonstrate the overlap between WASH and IPC, and in particular, the behaviors related to IPC, which require WASH services to be practiced. So certainly there's components of WASH and IPC that don't overlap, but in this green section in the middle, you have hand hygiene, environmental cleanliness and laundry, medical equipment processing, and healthcare waste management, which all require some element of water, sanitation, and hygiene in order to be practiced appropriately. We've heard a good deal about neonatal sepsis this morning, but I do want to note that we know that a vast majority of neonatal sepsis deaths occur in low and middle income countries, and research has shown that IPC and specifically clean birthing environments and cord cleaning are effective interventions. So this just highlights how crucial it is that we invest in the basics in water, sanitation, and hygiene if we do want to reduce neonatal sepsis. We can't forget the faces, those particularly impacted by the inability to receive safe care. I bring forward this quotation from a mother in Tanzania who is part of a UNICEF program who is faced with an impossible choice. And she says, "I was reluctant to give birth here at the health center with all these water, sanitation, and hygiene problems. I didn't want to risk my health or that of my baby, but delivering at home without a skilled attendant was equally risky." And this is the dilemma we are putting women and patients all over the world, particularly in low and middle income countries to face whether or not they should go receive care or put them at risk at the potential infection they would receive while receiving that care. So we know that a healthcare facility without WASH is not a healthcare facility. But what should it look like? Every healthcare facility should be equipped with the basic WASH services: water, sanitation, hygiene, waste management, and environmental cleaning. They should be staffed by a workforce that's trained on WASH and IPC, and that staff does not only include clinical staff. You must include those non-clinical professionals, particularly cleaners, who are foundational to an effective IPC program and are going to have day-to-day interactions with this potential infectious materials. And lastly, it needs to be funded by a budget which includes operations and maintenance to ensure that those WASH services are functional and available today, tomorrow, and in 3 years. How do we take action on this? So WHO and UNICEF have put together numerous tools on WASH in healthcare facilities. And in particular, they are directed towards specific levels within the system. So we have the WASH Fit tool, and this is a tool that guides health facility improvement through a quality improvement cycle. So this is the ability to put together a team, identify WASH concerns within the health facility, prioritize needs, and make a plan, improve the facility, and then, of course, evaluate this program. It's been used in over 70 countries since 2015 and demonstrated to actually incrementally improve WASH access within the healthcare facilities. The second we have is national level, looking at what we call the 8 practical steps. And this is essentially a health system strengthening effort to ensure that the enabling environment is in place for sustainable WASH. So are there the appropriate policies? Are we monitoring that WASH is available? Do we have standards and guidelines to guide how WASH is intervened into the healthcare facility? We've just done a recent survey and found that the action is underway in more than 100 countries globally to ensure that WASH services are available and sustained. And lastly, we have the Global Framework for Action. The Global Framework for Action focuses on 3 key efforts that we can be taking as partners to ensure that WASH services are available. The first is integration into the health system, ensuring that WASH is integrated into health policies, programs, budgets. The second is monitoring. We need better monitoring and better data to ensure that we understand what the WASH conditions are. And the third is developing the health workforce. So as I mentioned before, we clearly need to capacitate the cleaners, the clinicians on WASH services and how that links to infection prevention and control. And then we also need to bring together partners to increase investment. This is a major concern for the basics of ensuring you have safe quality care in the healthcare facility and can prevent concerns like sepsis from developing. Yet it's still massively underfunded. And so much of our advocacy and our efforts are to ensure that national governments and partners are investing in WASH, not only for that capital infrastructure, but also for recurrent costs. So what can you do? How can you, those of you here at the World Sepsis Congress, how can you help ensure that we have WASH in healthcare facilities and in our communities in order to prevent infections and to prevent sepsis, whether that's in newborns or in adults? First is be a hygiene champion. Walk the talk. It is going to be World Hand Hygiene Day on May 5th. It's a perfect opportunity to be advocating for hand hygiene, which we've heard throughout this morning about how critical it is for the spread of infection. So join these conversations and be sure you are championing hand hygiene within your own communities, within your own healthcare facilities. If you're working in low and middle income countries, I encourage you to check on the WASH conditions when you visit the communities, when you visit the healthcare facilities, and speak up about improving those poor WASH conditions you've identified, particularly in healthcare facilities where you may have particular efforts to be able to take action. And lastly, if you are part of the global movement to address sepsis, bring WASH to the table. I'm so grateful to be here, to be part of this conversation. We are ready to support your efforts, and we can bring the technical know-how, and we can bring the partnerships, which can then ensure that there's not only access, but sustainable access to WASH services so that we can ensure that we can all prevent the spread of infections and prevent sepsis. So with that, I'll leave it here and over to you, Dr. Maha.
Thank you so much, Dr. Lindsay. Before we conclude the session, I think I still have 2 minutes. I have a question to Dr. Mateusz from the audience. The question is related to, again, vaccine. How long does the AMR vaccine stay in the body, and does it affect the microbiome?
So just to clarify that the vaccines that I was talking about, they particularly target the pathogens that they are designed against. So they target diseases that are caused by drug susceptible, but also drug resistant pathogens. So there are no vaccines that are particularly just for the AMR component. And of course, they will vary depending on which pathogens we are looking at. There are some existing vaccines that we analyzed, like vaccines against Streptococcus pneumonia, which we know more or less how long they are working for. There are some vaccines like for RSV, which we know that the ones given to mothers, they could work around 3 to 6 months. But there are also some vaccines, hypothetical vaccines, like Klebsiella pneumonia, for example, where we needed to make some assumptions as to how long these vaccines could be working for. For Klebsiella pneumonia, given that this is a maternal vaccine, we assume that this would be 3 months. But all of these assumptions are listed in the report, and I invite you to read them. They do vary pathogen by pathogen, depending on what pathogen that is, and whether the vaccine is developed, and whether we know something more about the biology of the pathogen or of that vaccine.
Thank you so much. So that will take us to the conclusion of this session. I would like to thank all our speakers, our sponsors, and attendees. I just want to remind all of you that all the session of World Sepsis Congress will be recorded and will be released in scheduled fashion on YouTube's and podcast channels. Also, I would like to invite you all to join Global Sepsis Alliance social media platforms to support the move for world free from sepsis. And if you join our website, the GSA website, you can sign the World Sepsis Declaration. By that, we conclude the 8th session, and we look forward to see you in the remaining parts of the World Sepsis Congress today. Thank you so much.